with a couple here while we collect them. Raj, I'll start with what you finished with, which is electronic devices and EHRs. And I think sort of that inability to sort of unplug I think leads to a mental fatigue sometimes because you're sort of always available. They can always get a hold of you. Some thoughts on how to manage that.
I think it's a holy grail of the EHR companies to always set out a new fix that's going to make it better for us. And I haven't found one that actually works except to actually disconnect. I think that the ability for patients to send you messages at all times. I just recently got 4 messages from a patient on a Saturday for pretty mild questions, and the 4th one was, "You shouldn't work so hard. Why are you answering these questions?" And she kept responding right away anyway. So I think patients have developed this sense that things need to happen immediately, as well as our referring providers. I think you set the tone I set that tone, right? I replied on a Saturday, I replied again, and so I've set that tone. I think that all you can do is you have to set that tone early on. I'm not responding to non-urgent messages on the weekends, and that's a limit you need to figure out a way to set yourself, because I don't think the EHR is making our lives easier. It's making it easier for us to sort of delve back into the computer all the time. I mean, on the phone at all times, I can check everything, right?
Yeah, now you can check your EHR on your phone too. So.
All the time. I don't know if you have any other thoughts.
So a couple of questions here, again, related to that. One is you talked about this issue of system responsibilities, and I think you had an article from the Mayo Clinic. So what are some examples that large institutions have adopted successfully to help with physician burnout?
Yeah, the way the Northwestern model right now is to sort of create sort of the teachers, and then you have local champions that are people who are meeting in small groups to talk about how to reduce burnout. I don't think that the system can fix the problem. It can create a culture where the problem gets reduced, meaning a culture where you're prioritizing physician health is helpful, but also where, as peers, we're sort of looking out for one another, right? That's why this physician engagement is such a big thing right now in medicine. It's that happy physicians tend to take better care of each other as well. And that's probably the main thing that we can do. I think if we all model good behavior, if you're a leader, as you are, if you sort of ask your physicians to all add on 2 hours of clinic every day because of sort of a bottom line, or you even say, "Oh, I'll do it myself, you can decide what you want to do," you're basically modeling a behavior that everyone's going to follow, right? So I think it's basically modeling behavior is the best you can do. But I think you're basically trying to train people on how to sort of reapproach medicine in a more balanced way.
Yeah. So, Bill, you kind of pointed out this issue of the true adenoma rate, and we have an ADR that we detect, and there's a gap, and that you're going to hopefully close that. Just I wanted to probe into that a little bit. What do you think the actual, like when you've run your analyses and you have this near complete, what is the adenoma miss rate, or what is maybe the average actual adenoma rate in our population? We've sort of said 30 and 20%. Do you have any sense of what our miss rates are?
Well, we do know from the tandem studies that, somewhere around 20 or 30% of the time we're going to miss a diminutive polyp. So that's a back-to-back colonoscopy where the second colonoscopist finds a polyp that was missed by the first colonoscopist. Well, if it's 20% each time, that means the next colonoscopist, if it was a tandem in 3, would find 20% more probably. And it would go on and go on and on. The bottom line is we don't know how many, what the true prevalence of polyps actually is. We can only make estimates based on who has the best ADR within a given cohort of patients that are all the same. For example, in the Kaiser study from Northern California, there was one who had an adenoma detection rate of 54 and presumably had the same cohort of patients as everybody else. And these were screening colonoscopies. So it's somewhere up there. I know Doug Rex is estimating it to be about 54 or 55%. Now, some of you may work at the VA, and it seems like if you only find adenomas in 54% of your patients, you're not finding enough.
Right.
So
right.
Cohorts are important.
One concern that I've heard with AI is if suddenly we all become have an ADR of 60%, you have an enormous number of people now who fall into the surveillance category, which is a more frequent colonoscopy rate.
Yeah.
I know that there are some recent guideline changes, maybe that talk about attenuating surveillance in this month's gastro, and of course this is March. What do you think about that, and you know, how might we manage that? Is that an unintended negative of our AI and improved detection?
In the short term, but in the long term, what it means is that you've cleared the colon, right? So theoretically, you shouldn't have to do, if you've totally cleared a colon, you shouldn't have to do a colonoscopy at such a short surveillance interval that we're using now. So over time, as we learn more, as we get better, and we keep finding that we're not finding any polyps when they come back in 3 years, in 5 years, that we're going to probably readjust those surveillance intervals.
Yeah.
The bottom line is leave no polyp behind, right?
Right. So you were talking about the timelines in terms of this. Sort of a two-part question here. One is, how soon are the folks in the audience going to be able to take advantage of kind of some of the stuff you showed us today? And the second thing is, which I'm sort of curious about, is we're sort of in this area now where, as endoscopists, we're taking out larger and larger lesions. We're taking out big polyps. You know, I know that Michael Bork has sort of shown us, based on imaging characteristics, we may be able to have some sense of the risk of cancer and potentially whether it should go to surgery versus ESD versus EMR. So that's sort of a next level, predicting pathology, but then also predicting risk of malignancy. Is that something that you're working on, and how long might that take?
That's not something we're working on because those are so much more rare, right? How are you going to, I mean, we developed our polyp detector with 10,000 polyps. We did our optical path with, 10,000 of hyperplastic polyps, serrated polyps versus adenomas. You're not going to find that many advanced lesions that do and don't have cancer to be able to do a really good training, I don't think.
Yeah.
But eventually, I mean, if everybody gets on board, for example, if, one of the biggest problems is that each institution guards their own data. They don't willy-nilly share it. And so it's really been a struggle, like for Jason, to try to get a consortium together for the dysplasia in Barrett's to get enough to really make something robust, because you go to one place and it's just hard to get.
Yeah, well, maybe an advantage for these companies that store video that may have it, because they passively acquire this from a lot of places. So
Right.
that's an interesting option. If you have questions, like I said, I certainly want to make sure I get all audience questions involved. Raj, in terms of, you kind of talked, you had a lot of slides, interventional endoscopists versus general, and you had some stuff on surgical oncologists. Is there a significant difference in rates of burnouts among proceduralists and non-proceduralists with regards to physicians, or is it really more the job in general? Do we know anything?
It's interesting. We know a lot about it, but I think what we know is that there's high rates of burnout in both, but for different reasons, right? So I think most surgeons and endoscopists tend to have reasonable rates of, sense of personal accomplishment, but emotional exhaustion, things like this can sort of pick up. Some of the people who have the highest rates of burnouts are actually hospitalists, right? They're not proceduralists. They tend to just have this low sense of personal accomplishment. So to answer your question in a different way, there's different reasons why everyone can have burnout. I think it's figuring out what it is. And people like surgical oncologists, interventional endoscopists, it's just the fatigue of sort of complex care, medical errors, things of that sort. I think in someone who feels like they're dealing with end-stage dementia patients in neurology, it's not that they're making errors. It's just that the work itself is just emotionally exhausting, right? And so everyone hovers around that 40 to 50%. It's why they're hovering around that mark. We've seen that it seemed like younger physicians, gastroenterologists, and people who do more complex gastroenterology procedures tend to have higher rates of burnout. But I think you're still dealing with high numbers in both groups.
Is there any data with regards to sort of, folks that, are involved in sort of a variety of things, maybe involved in, like you said, being involved in social sort of activities with professional societies or other sorts of aspects, or is that something that can either be beneficial or detrimental? Is there any data sort of showing wellness associated with those sorts of activities?
There's definitely a lot of data in terms of being involved in your local community, sort of not even specifically sort of your medical societies, but local community, you know, whether it's some religious group or sort of other volunteer work. I think the sort of extreme of that is being overcommitted, right? And so this is like a little bit is good and a lot is bad. And I think that's especially true for sort of working in sort of medical societies, right? Being involved in something besides just, you know, patient care is good if you want to do some national society work. But there are plenty of people, I sit in clinic and listen to people complain a lot. It's one of my pastimes. And, you know, I'm so busy, I have to go to this meeting and then that meeting and then that meeting. And well, then you're not really sort of, it's not helping you combat burnout. Now this extra work is your burnout, right? And so it's sort of finding that balance right there.
Bill, I think I asked you a two-part question. I don't think I gave you a chance to answer the second part, which is the stuff that you showed us today, you know, how far away are we from that? And what are kind of your major logistical hurdles that you still face before coming to market?
So with respect to polyp detection, the FDA has made it very clear to us that this is a low-risk device, and I'm sure it really, truly is a low-risk device, that we really don't have to have a huge bar in terms of improvement, but we need to show that there is some improvement with its use, that there's some use of it. So the multi-center studies that the different companies are getting engaged in now are primarily looking at number of adenomas per procedure with AI on versus AI off. And ADR is kind of a secondary one because it takes a lot more cases to get an ADR. You have to have a pretty big study to do an ADR study. But we believe that our study should be complete before summer. And if the data is good and we get FDA clearance, it would be out by next year. Again, optical path is something that is going to require another study. We're not planning that one until maybe starting in the summer. It's going to be a smaller study. It doesn't have to be very large. And so I would think that something could be out there just in terms of maybe we could call it automated adenoma detection rate and not try to make any claims related to resect and discard or leave alone. But just here's an automated way to get your adenoma detection rate that, we could have that out there within a year and a half or 2 years.
And what you'd be purchasing here is really a software program. You just have a monitor that would analyze, and then essentially I think you had two monitors side by side, sort of the standard, and is that how it would work?
You don't need two monitors. In fact, at UCI, where we have this running in 7 rooms all the time, it's just one monitor.
Okay.
And you can switch it off if you decide you don't like it with just hitting a button on the monitor. It's just a computer that sits on the floor. The video comes in from the processor. Video comes out to the monitor. That's all there is to it.
I see. So you're essentially purchasing a
computer with
software on it.
Yeah.
Can I ask one quick question? I mean, you mentioned this sort of not moving towards resect and discard potentially, which would really, as the audience well knows, resect and discard would be the idea that you say it's an adenoma, you remove it, you don't send it to path. Gigantic cost savings to the healthcare system.
Yes.
Is the potential, do you think that's a potential impediment for where many places own their own have some sort of share in the pathology labs? And so is that one of the reasons you think that you're not maybe moving towards that direction?
No, we're definitely moving toward that direction, but to have something out to market, if we go out with just this is ADR, it can get out there much quicker.
Right.
To really show that it has the kind of, to achieve the PV thresholds for resect and discard and leave alone, that's going to take a little bit longer, but we're definitely moving that way.
Oh, there we go. There's a question right there, sir. So what you're saying is if you increased your ADR by 20% and reduced your risk of missing polyps, extending a post-AI colonoscopy to a longer interval, right, to maybe even 10 years, is that what you're suggesting, sir? Or earlier than 10 years? I'm not sure I follow you.
I think if I could try to read, I think you're saying if people are missing up to 20% of adenomas, pre-AI, you saving the world, should we be reducing that 10-year interval to something less? And is that
I think most of the polyps we're missing are diminutive ones. So that 20% is predominantly diminutive polyps. And the dwell time for a polyp is typically about 10 years for a polyp that actually will turn into a cancer. The rest may sit in there for way beyond your lifetime. So I don't think that means we have to be, because we're missing 20%, that should be a readjustment for what we're doing now. I think what we're doing now kind of accounts for that.
Yeah, I mean, not to sort of belabor the point, but the people who have pre-AI very high ADRs have a very low rate of interval colon cancers, right? So the excitement in this space to me is getting people who aren't at that 55%, to that number, right? Because I think if you have a high ADR and you have a normal colonoscopy, your patients are protected likely closer to 15 years even than 10 years, right? So people who perform high-quality colonoscopy, pre-computers helping us, their patients are at very low risk, but there are many people who don't achieve those metrics right now, and so this is hopefully going to level the playing field to where everyone is sort of getting a colonoscopy by someone with the high rate and quality metrics.
I was actually taking that question the opposite way, which is that if you have a high confidence, you said 85%, I think, or so of the polyps, it's sort of us, incomplete resection or a miss, and only a very few are at the true interval development. So the thing is, do you think that someday that if you have AI, you'll be able to further elongate a positive colonoscopy, which might help a source mitigate the effect of the fact that you're going to have higher ADR rates?
I think so.
Yeah.
If you're polyp-free, if you're truly polyp-free after this colonoscopy, the chances that you're going to make a polyp the next day and get a colon cancer within 10 years is really small, unless you've got a genetic predisposition. Obviously the other factors that come into play are your family history and other things that would affect your surveillance interval. It's still, if you had 12 polyps, adenomas in your colon, and you cleared them all out, you're not going to give that person 10 years ever.
Bennett.
One of the other features, though, and I think this is covered in the gastro article and another one that is similar, was the size of the polyps and how it was taken out, whether it was an ESR or a piecemeal resection. That goes into this situation.
Yeah, size is part of it as well. Yeah.
Size and technique, and I think there's
technique.
some data right now that suggests cold snaring polyps as opposed to forceps is probably associated with lower rates of recurrence in small adenomas. I think Icopol and others.
Right. Agreed.
Okay. Yeah. So I think for those who didn't hear, I think just that there's other factors associated potentially with these sort of recurrences, which include both the baseline size of the polyp, as Dr. Roth was saying, as well as how you remove it, and obviously, adenoma recurrence, large polyps, but even small polyps may be dependent on technique. So.
And just one more editorial comment from me, because this is what I like to think about, which is that the AI will help you, but this is going to put even more emphasis on your technique of colonoscopy insertion, cleaning, and all these things, because as you obviously know, it's not going to find polyps that aren't on the screen, right? And so that's why some of the most interesting work to me is the prompting of you to say, hey, you didn't look behind that fold, or you didn't clean that colon, you're not doing such a good job. So this is going to accentuate even more what makes you a high-quality detector versus not. Now it's probably partly recognition, like you recognize flat polyps, you have good vision, those sort of things, as well as the quality of inspection. As this takes hold, it's really going to be you controlling that scope and how much information you give the computer to look at. So I think it doesn't make us all equal just because the computer's there. We have to actually work on our technique.
I have a question for all of you. Do you want AI to be a policeman? To tell you to slow down, to stop, to look behind folds? Is that something you'd like to have, or Would you prefer it just giving you some information about like surface area that you've missed as you've pulled out and let you make a decision? There's a Chinese group that just came out with a speedometer of withdrawal that was shown to be nicely, the use of it beautifully correlated with higher ADR. So, I mean, that's something you could have a speedometer, and at the end, you know, you're given a speed score on your withdrawal.
Hopefully not at the end.
Right.
I got to start over again.
And
Go back
another
and do it all
quality
over.
measure to report to Medicare, right?
One of the issues is withdrawal by itself, unless you subtract polypectomy time. You know, the AI going to tell you that.
Yes. Ours can do that already because it knows when a polyp is seen, when the snare comes out, and when the snare goes in. And when it doesn't see a polyp anymore, that's your polypectomy time.
Okay.
Yep.
Yeah. So before we break, first of all, I want to thank you both for some very thought-provoking sort of talks and a really excellent session. Thank you.